I would like to introduce you Savva, who is like a commercial IP lawyer and a crypto legal counsel and patent attorney for more than 18 years. He founded crowdfunded Cures in 2013 and advises various Web3 projects, including VitaDAO and Molecule. And he conducted his LLM thesis, which is like his Master of Law on alternatives of the patent system for developing medicines. So Savva, go ahead and tell us more about your Pay for Success scheme.
Awesome. Thanks, Max. Thanks so much. Can you hear me okay?
Yes, we can.
Okay, I'm just going to try and share my screen. Fingers crossed this works. So is that working?
That looks fantastic.
Okay. So yeah, my name's Savva Kerdemelidis. I'm, as you mentioned, I'm an IP lawyer and patent attorney, and I advise Molecule and VitaDAO and a few other crypto projects. But my main interest is actually around IP incentive design. And I think there's a lot of definite overlaps between what Molecule and VitaDAO are trying to do in this particular mechanism, which is basically a way to incentivize development of medicines where the patent system doesn't work very well and it hasn't really been serving us. And I'm going to make the case that by implementing an alternative to the patent system, we can help drive cost savings and potentially generate new longevity drugs faster, sooner, and that are safer and without reliance on patents. So, so I'm from Crowdfunding Cures as well. Crowdfunding Cures is a charity I established in 2013 after I did my master's thesis on the topic. And more recently, we've had a few volunteers join. Since COVID, we've really picked up a bit of momentum, and since reaching out to VitaDAO and after their raise last July, I think we've been getting a lot of support from the community around this particular model and what it could potentially do. So one of the core problems we're trying to look at is around healthcare costs, which are soaring. It's probably around 20% of US GDP. There's this kind of aging baby boomer population, which is just going to take more and more healthcare costs, particularly due to aging. And the other issue is around pharma R&D at the same time. It's this principle called Eroom's law, which basically shows that pharma productivity is decreasing over time. So the cost per developing every new drug is over $1 billion now, and it's kind of exponentially increasing. And what we would argue is that this is part of the problem, is that the patent system is causing a lot of distortions, market distortions towards drugs where it's possible to enforce a monopoly price, because that's the only way you can get a return on investment under the current biopharma model. So essentially, pharmaceutical companies will never fund large phase 2 and 3 clinical trials for anything unless they can enforce a monopoly price. And that's particularly the case for therapies which are off patent, where you cannot, where the active ingredient is available on the market from multiple sources. So as a result, low cost, safe and effective treatments are being ignored. So there's this massive opportunity, particularly in the generic space. There's around 90% of the drugs that are prescribed in the US are generic drugs. There's around 1.5 trillion in cost savings over 10 years for using generics. And in fact, even on a shorter time frame, because the fact is that generic drugs essentially are available for extremely low cost compared to the cost of patented drugs. So they're essentially, their marginal cost of supply is almost zero. But that's the sort of essence of the problem, is that essentially there's no financial incentive to repurpose those drugs, and there's this tragedy of the commons essentially. And also there are a bunch of other therapies which don't quite fit into the patent system and patent model, things like diets and supplements, and also more generally non-profitable therapies like antibiotics and neglected diseases. So one of the issues is around generic drug repurposing. As I was saying, there are thousands of off-patent drugs, generic drugs. They form the majority of the US prescriptions. The problem is that because they can be prescribed off-label by doctors, then doctors do not have, or pharma companies don't have an incentive to find new uses for those drugs. The fact is that most drugs, in fact, I think around 90% of drugs have more than one use. And the issue is as soon as they go off patent, their chance of being repurposed for a new use approaches approximately zero. Before they go off patent, they might have around 30% chance of being repurposed. But there are a number of drugs that that basically could be like miracle drugs essentially, but they happen to be off patent. And can treat very serious illnesses like, for instance, paracetamol, which is a form of vitamin D, has been shown to be effective against treating late-stage pancreatic cancer. One of our advisors actually was a patient, and he had stage 4 pancreatic cancer himself, and took paracetamol as an adjunct therapy. This was developed by the Salk Institute through public funding. It's sort of taken over 20 years to develop, but there are no private incentives to do this kind of important research. There's been attempts to address this particular market failure through providing orphan drug exclusivity and data exclusivity. The issue is, as I mentioned, in the same way with patents, is that you can provide exclusivity, but if doctors can prescribe the drug off-label, there's no way you can enforce a monopoly price. Doctors can just get the old version of the drug and tell patients to take that particular drug if it's so there's basically no market to do repurposing unless you can reformulate the drug in a way that doctors will not prescribe it off-label. But even then, there are compounding pharmacies that will basically reformulate your drug for you. And also, a lot of drugs, reformulated drugs, might be just as effective as the off-patent drugs. So it's a bit of a false, a short-sighted way of enforcing a monopoly is doing this reformulation. Although it does work in some ways, obviously there's not a spectrum, but there's cases where there have been successfully reformulated drugs. But we're really interested in the generic drugs that have nominal or almost no reformulation, and they're effective in that particular modality. So as sort of alluded to previously, there are particular considerations around pharma company has to take into account when developing a new drug, particularly is what is going to be the return on investment. And as part of that return on investment, they have to be able to enforce a monopoly price through reformulation or through patenting the drug. But there are these categories that are called financial orphan drugs, essentially off-patent drugs, nutraceuticals, lifestyle interventions, these things which don't fit into the patent system, and pharma basically will never fund large phase 2 and 3 clinical trials without being able to enforce a monopoly price. So we have this market failure essentially, and it's exacerbated by the fact that it's actually can be up to 100 times cheaper and even 10 times faster to repurpose a generic drug, because you can, the drug has already been around on the market for 10, 20 plus years. So you can start phase 2 or even phase 3 trials immediately. So there's this huge arbitrage opportunity that's not being tapped by the market, by the private markets, because there's no way to capture that any of that upside. There's also massive cost savings for government as a result of incentivizing repurposing of drugs, but again, no market mechanism to capture that upside. Estimated 2.2 trillion in US taxpayer savings in 2019 through the use of generic drugs, because essentially these drugs are extremely low cost. But that's the issue, is that there's no way of incentivizing new uses for those drugs, and no recognition under the patent system that the value of a drug is not so much the chemical formula, but the treatment protocol showing that this particular chemical formula is safe and effective in patients, at least under the patent system. Unless you can enforce a monopoly price, you can't basically make a return on investment for showing that. So, I mean, this isn't science fiction. There are a number of generic drug repurposing opportunities. I'm not going to go through all of them in detail, but there's been, you know, there are always news articles that come out that talk about particular off-patent drugs that can be effective and that lack financial incentives for development. I don't even want to talk about ivermectin and hydroxychloroquine because of the controversy around that and COVID, but those are very salient examples that everyone seems to know about, and it's like dinner table conversation. But, you know, I'm agnostic as to whether these things are effective or not, but the point is that they show that there is this market failure. And even now, like, I think there's been about $6 billion spent on looking at things like ivermectin through public funding, and we're still pretty far from a definitive answer. So it just shows that public funding of very small, low power clinical trials are just going to exacerbate the confusion in the market, and that we need an actual serious market incentive to do this generic drug repurposing, so we can all be certain, and we can't just rely on government to do this sort of thing. So there's a few different use cases here: oxyphenylbutazone, low-dose naltrexone, treat chronic pain; clomipramine, treat brain tumors; simvastatin for MS; tetrathiomolybdate for preventing recurrence of breast cancer; BCG vaccine, one of the first vaccines made, could be repurposed to treat type 1 diabetes. It's also useful to treat COVID, ironically. I just got COVID myself today. So maybe I could have prevented that with some BCG vaccine to boost my innate immunity. Dichloroacetate also got quite a lot of press back in the day, and a lot of people taking it and just ordering it themselves for brain cancer. And again, it's off patent, so it's basically available to be ordered online. So no private incentives again to do that sort of research. One that's a bit controversial, but actually has some real science behind it. It kind of fell out of favor, and is actually as a researcher actually from my hometown in Christchurch, Professor Margaret Visser's looking at using vitamin C, high dose IV vitamin C, to create a hypoxic environment, and can treat cancer. One also more recently in the COVID space is fluvoxamine, and that has been shown to reduce hospitalizations by up to 90%, and deaths by up to 90% in a Brazilian clinical trial, and there are efforts to try and get that approved in the United States. But at the same time, we have patented new drugs which are perhaps less effective, like Merck's new drug, where the US government has ordered over $1 billion worth of this drug to stockpile it, and it might actually be less effective than this off-patent drug. So again, it shows that there are misaligned incentives under the current patent system, and that there's a need to try and implement ways to fix this particular issue. One really low-hanging fruit, and I think there's a lot of empathy around with the VitaDAO and the crypto community, is around the use of plant medicine. For example, it's a very salient example of the market failure under the patent system, where you have cannabis being prescribed to thousands and thousands and probably millions of people to treat chronic pain, but there's no FDA approved version of cannabis. And I would say that the reason for that, and the obvious reason for that, is that it's not possible to enforce a monopoly price over cannabis. There's mannitol, which is basically it's a THC derivative that they patented, and it's specifically used to treat cancer pain, but not broadly more chronic pain that might be compete with, say, opiates, which are causing massive political and social problems in the United States. Estimated over $1 trillion a year in overdoses, due to overdoses and public harm. But as we know, it's not possible to overdose on cannabis. So this is an extremely salient example of the market failure under the current patent system, because you can't enforce a monopoly price. Similarly, psilocybin has the same issue. You can grow it, anyone can access the active ingredient. So these things are considered unmonopolisable therapies in the same way as repurposed generic drugs are also considered the same. So the issue is there could be an optimal treatment protocol for psilocybin in combination with, say, a talk therapy or VR or some sort of dose. And research around that will only ever be publicly funded unless you can tweak psilocybin and create a patented version. And that patented version might not be as safe and effective, and also kind of goes against a lot of the community support and the thousands of years of oral and tradition around use of plant medicines, which could also have potential safety and efficacy implications. And the other issue around psilocybin, obviously, is that one of the active ingredient, as it were, might be just having an epiphany or like a peak experience, essentially, where you integrate a lot of past traumas and things like that. And that doesn't necessarily need to happen with a patented tweaked molecule. So as soon as if your drug company takes a tweaked molecule to market, then some clever person will just do a head-to-head study against normal psilocybin using your treatment protocol, and then that basically means that your drug is essentially the same as the off-patent version anyway. So it's not really justifiable for you to charge hundreds of millions of dollars or a monopoly price for it. So it's kind of gaming the patent system in a way. And it's basically the elephant in the room, I believe, for the business model for cannabis and psychedelics and plant medicine in general. So definitely needs to be a problem. There's a problem that needs to be solved. So as we've said before, repurposed drugs require large phase 2 randomized controlled trials for FDA approval. It is possible to take drugs off label, except the smaller the trials, you're less likely to have doctors prescribe it. Doctors really want the highest level of evidence for prescribing drugs, and for FDA approval, that means phase 3 clinical trials to show that this is statistically significant and better than placebo, or even better than existing drugs out there. And without that, doctors will not, mainstream doctors will not prescribe this particular drug. And so you have patients that don't have access to life-saving medicines, essentially, or at least are unlikely to be treated. So the question is around, like, well, why not just use public funding? Why doesn't the government come in and do this stuff? The issue is that particularly large clinical trials, over 90% are funded by private capital. Governments, nonprofits, and private philanthropy do not want to fund large clinical trials just because of the high cost and the risk, particularly political risk for government. They fund a large phase 3 clinical trial of $10 million and that fails, that's going to be all over the papers. Whereas if a private company does it, nobody really cares. So there needs a mechanism to kind of de-risk these clinical trials. So that's where we're introducing our solution. Essentially, this handy cartoon kind of is a way to show different players. So you've got a doctor that wants to prescribe generic drugs off label. You've got but they don't have clinical trials to show that this is large clinical trials to show that it's effective. An investor wants to repurpose clinical trials, but there's no way for them to get their money back. And health insurers really want people to repurpose, to repurpose generic drugs, because then they can save a bunch of money, and they would gladly recoup anyone that does it, but there's no mechanism to do that. So this is where we introduce the pay for success model. Essentially, an insurer says, here's a bunch of money. If you do the repurposing, we will give you this money. And then the investor says, okay, fine, we'll do it. And we'll spend a smaller bunch of money on doing the repurposing, but we understand that they will take on a risk and there's a chance that the clinical trials might fail, but we're okay with that. And then the investor goes to an independent contract research organization to do the clinical trials. So then they do it, and then they get the treatment protocol. They give the treatment protocol to the insurer, who then applies it to reduce hospitalizations and save them money. So this is in a schematic of the pay for success mechanism. I mean, you've got the impact investor basically providing the upfront funding for repurposing a generic drug. You have a researcher that actually does the clinical trials, an independent clinical research organization. And then you have a payer that pays for the successful clinical trials, and that would typically be a government or a health insurer, but also could be large philanthropy or crypto whales, someone looking to bootstrap this particular model or try this particular pilot, which we'll talk about at the end. We are trying to do this pilot for a phase 2 clinical trial for Rapamycin. So we'll get to there. Sorry, I just thought I'd provide a bit of background. But we do want to do a pilot pay for success contract using Brad Stanfield's Rapamycin plus exercise trial. So these are the different stakeholders. Basically, as I was saying, there's the payer, which is a government or an insurer. Impact investor is just your typical investor, except they're investing in public goods. This pay for success mechanism has also been tried in the context of something called a social impact bond. So these are new financial instruments that have come around in the last 10 years. And basically, they work in exactly the same way. They pay for outcomes and backed by the government, and say, for instance, to get private investors to help reduce homelessness, then the government will say, if you can get a homeless person off the street, we'll give you $10,000. Or if you can reduce prisoner recidivism and get a prisoner so that they're not, they don't go to jail for a year, we'll give you $10,000 on the basis that we'll save $100,000 if that's the case. So that will incentivize basically private companies to deliver public goods. And in the same way, social impact bonds have been proposed by, or pay for success contracts have been proposed to do this for generic drug repurposing by Bruce Bloom, Dr. Bruce Bloom, but that hasn't been implemented yet. And this is what we're trying to do, is carry on the torch. Again, as I was saying, there's a large amount of cost savings. So I think that's a way to basically fund the study. I think that's one of the main objections, is like how to get a payer. Without a payer to actually agree to pay for a repurposed drug, there's no incentive. But the advantage of a pay for success model is they don't have to take on any risk. They just agree to pay if there is a particular outcome, but they don't actually have to put any money up front. And then they sign a contract saying they will pay if there's a successful outcome. And on that basis, investors can then raise a fund to do the generic drug repurposing. So I alluded to the advantages of the traditional direct funding. So you're transferring risk from, say, a government or a philanthropist to an investor who's willing to take on that risk. Pharma industry also a lot more well-funded, and there's basically better qualified than the public sector in some ways. They've got better equipment. Also, the free market is very efficient at delivering things, as long as there's money to be made, in my view, more efficient than centralized public funding. So leveraging the markets to do this sort of work is going to be very efficient. Also low cost. So repurposed generics are about, they could be 100 times cheaper than developing new patented drugs. So you're looking at much lower costs per quality for generating new drugs. So they should, this mechanism should, in theory, outcompete the patent system. So why longevity? There are a number of generic drug repurposing candidates in the longevity space. I'm not I'm sure I'm not an expert in this space, but I'm sure there are a lot more than this particular one. But here are just some of the main ones. So things like rapamycin, NMN, resveratrol, metformin, vitamin D, nicotinamide. Also, why DAOs? Why use DAOs? So VitaDAO have created this IP-NFT framework that will allow investors to invest in a fractionalized way. With this mechanism, we can actually use open source IP-NFTs for investors and open source NFTs to raise a payer fund, basically to stand in for government. So, you have a bunch of people saying, hey, I want to create a longevity drug and that's off patent, and I'd be willing to pay $1,000 for that. So they would put that money into an NFT, and that would create a market model for doing this sort of work. And this is basically a scalable open source business model for creating public good medicines. And there's a lot of advantages to using Web3 technology. For instance, it's globalized, secure, trustless, decentralized, and ultimately just reducing transaction costs and providing access to liquidity. So finally, we introduce our pilot, and this is what we want to do to try and get this off the ground. We're looking at supporting Dr. Brad Stanfield's rapamycin plus exercise trial in a pay for success contract. The criteria for a success would be an improvement, a trend towards improvement in the 30-second chair stand test. And this model shows that that basically this would allow, we're trying to aim for, like, say, $100,000 to $1 million in a payer fund. If we can't raise $1 million, then there'll be less. And say VitaDAO, say it's 100,000 as a fund, and we're also partnering with Longevity Prize to try and raise a payer fund. If we can raise, say, 100,000, then maybe VitaDAO would be willing to put 50,000 in as an investor in return for getting 100,000 outcome payment from the prize fund, and using the IP-NFT framework to actually facilitate this. If we can raise $1 million, then they could put in the whole amount, 400K, to actually fund the entire trial. So this is a risk transfer mechanism. It is new. And that's what we're trying to do, and to help create open source medicine. So if there's any questions, happy to take them.
Awesome, Savva. Thank you for sticking so long to the project, and also bringing everything together and focusing on longevity, and trying to get some of those trials that really can make a difference off the ground with that, and thinking in an entirely different way, or in a non-traditional way of how we actually can use what we already have. And yeah, we've got a question from Sterling, who asks, what are the legal and cost hurdles from pharma industry patent challenges? Couldn't pharma...
Okay, so I mean, this is the best thing about the model. It's basically got open source baked in. So even if you had a patent, there's just nothing to sue. You can't really sue people for using an off-patent drug. That's the whole point. So if you publish the protocol and say rapamycin is an effective treatment protocol for improving longevity, someone could come and say, hey, you're infringing my patent. Well, good luck suing every individual doctor and patient that takes off-patent rapamycin. It's just not a viable business model. And it's a little bit like Napster, and with the, where the, maybe Napster's not the best example, but where you have this file sharing and the traditional kind of music industry trying to shut it down. You basically can't stop the information once it's out there.
With regard to off-patent drugs, I don't know what the exact rules are, but it's 70 years or so until a drug is off patent. So how many of those drugs are actually out there? Is it the majority of drugs? Or
yeah, you'll be surprised, actually. Most drugs go off patent around 10 years after they get on the market, because it takes around, so a patent lasts 20 years and you can extend it for 5 years, but then it takes around 15 years to get to market. So you're looking at most drugs are on patent for about 10 years and they go off patent. So there are a lot of off patent drugs, like thousands and thousands and thousands. We're not going to ever run out of substrate. There's a lot more off-patent drugs than there would be patented drugs.
Oh, wow. Okay, cool. We've got like another question. How are you thinking about incentivizing payers for long-term work? Like if their patients are not staying with the same insurance or insurance year to year?
Yeah, I mean, there's an issue with first mover advantage. I think, with payers, ultimately you want to kind of get a syndicate of payers to join together and agree to honor a pay for success contract. But one way around it potentially to give an advantage to payers is to say, if you stay with this particular insurer, you will get this particular FDA approved version of the generic that has the new label on it. So there's some way of actually providing some incentive for people to stick with a particular payer. And, a lot of the cost savings for payers might actually be apparent very quickly as well. The payer might get an upside very, very quickly from, say, having, repurposing rapamycin to reduce their hospitalization costs.
Cool. And like one last one from Sarin. My understanding is that your proposed metric for success in the PFS contracts are QALYS, QALYs. Are you considering other metrics such as cost savings or CMS? An example, Medicare, Medicaid.
Yeah. Hi, Sharon. So quality adjusted life years is just one particular metric, I think, to determine success. It's not the only metric. You can essentially have any outcome you want. You can design a contract in any way you want. They're completely flexible. It's like software. So yes, we could definitely look at cost savings. In my view, I think we should really avoid cost savings because payers are very reluctant to share that sort of information, and they might not even measure it. In my view, it makes a lot more sense to just price these repurposed drugs as if they were patented drugs, and then and that's typically how payers determine the price of a new drug, is to determine like how many quality adjusted life years will this drug add, and then they're willing to pay, say, $50,000 US per year of healthy life that this will extend. So it's just basically quality is like a price finding mechanism, or it's a tool, a pharmacoeconomic tool. But yeah, we're not particularly wedded to using qualities and its contract, so it's completely flexible. It's basically whatever the payer wants. For instance, for our proposed rapamycin clinical trial, there's no qualities. It's just success is there's a trend towards improvement in the 30-second chair stand test, which is just something that, an arbitrary outcome that we decided would be valuable.
Awesome. Cool. Thank you very much, Savva. And I hope you're getting better and COVID cures itself.
Yeah.
And yeah, I guess with